Well, then I like to, get high and make dinner and, hang out with my family. And then I take a guitar off the wall and get a little bit higher and see if there's some music out there calling for me.
Another problem in cannabis is the presence of pesticides or fungicides.
Talk about the farmers, they have the knowledge of cannabis. And now we are adding this knowledge to the scientific knowledge that we can get from outside.
It's Reefer Madness, the podcast, with Trevor and Kirk.
And Renee, that's me. I'm back here in the studio. We're going to continue a conversation that Kirk had with Dr. Johannes Thrul. And here's Kirk from the last episode, E173 Part 1, explaining a little bit about Dr. Thrul.
So anyways, so what I discovered is that this guy belongs to a team of other researchers that are trying to set up a national database of medical cannabis users with the hope that they can have a library that they can distill out to people on cannabis. It's a fascinating story, National Cannabis Study that they're doing, and their hope to gather information about medical cannabis from around America and the world. So that's basically the story.
And without further ado, here's Kirk with Dr. Johannes Thrul on Reefer Madness, the podcast.
First of all, let's start. This is a huge database you're proposing. How far along are you in gathering this information?
Yeah, so we're at different stages based on for different sub-studies. For the prospective data collection, the National Cannabis Study, we're still relatively early on. So we built a pretty robust system that has, been put through the paces. With online research these days, it is non-trivial to set it up so it's well protected. Early last year, we were savagely attacked by a swarm of bots and probably humans in the loop that initially it was very easy to determine what is a bot response versus a real participant. But over time, they learn and get better, so it gets really tricky. So now we had to essentially re-engineer everything from scratch to build really robust security systems that now essentially requires folks provide an ID that gets checked against the facial biometrics to make sure that they're real participants, because we pay incentives for survey completion, which means that it becomes very interesting for people to scam research studies like that.
Sure.
And with, large scale AI available to anyone and everyone, there are a lot of people who have an interest in getting into research studies like that. So that's kind of the trade-off we have to make. We have to be really diligent about protecting the data quality.
Fair enough, which leads me to the next question in tombstone information. When I decide as a user to say, oh, look at this study, I can participate in this, what tombstone information are you asking from the individuals? Are you taking zip codes, ethnicity, social terms of health? What information are you gathering about the individual besides their cannabis use?
Yeah, so at baseline, we're getting a lot of this type of information. Obviously, we want to know people's background. And then a lot of the measures we have, this is maybe something we haven't talked about yet, but we have suggested measures on the website as well. One that we developed ourselves, the Cannabis Use Questionnaire, that gets at really detailed cannabis use. We talk about what are the facets that are important, as in what are the ingredients of the product, what is the dose that people are using, what is the route of administration, frequency, quantity.
When you CQTs, you called them? Is that what it was?
CUQ, Cannabis Use Questionnaire.
Cannabis Use Care. Okay.
Yeah, very creative.
Yeah. But it sounds like you've standardized those questions so that anybody who's doing cannabis research can go to that standardized list of questions so the data is consistent. Is that one of the goals?
Yeah, so we're hoping that it will be a service to the field to help put out what we think are the important facets of cannabis use that we recommend folks to assess. Now, we've started talking about the changes in the marketplace, right? I don't think this is ever something that's static. So there will be new products on the market that maybe our current iteration of the instrument isn't capturing well. So the approach that we took is that, so I guess I should start by saying that this tool is available for folks to download off of our website in ready-to-go versions for RedCap, for Qualtrics, common survey systems, where you can just import it into your platform and run with it. You don't have to start programming from scratch, which took us months to do. But now, knowing that the marketplace is in flux, right? The products that are available today might not be the products that will be available tomorrow. So this platform, this questionnaire, the tool, has to evolve with time as well. So the approach that we took is that once folks want to download it, we ask them to register with an email address. So we have essentially a list of folks who have at some point at least downloaded and looked at the tool. Whether or not they're using it, I don't know, what can I say. But once we make updates to it, those updates will go out to everyone who has registered to download the
tool. So how deep do you get then for personal information? Do you get the person's individual names? And I mean, obviously birth dates and zip codes would be helpful, but do you get down to, do I put my first and last name into this database?
This is not information that will be kept with the health information, right? So the data will be kept separate from identifiers, and then especially once the data will get analyzed or open to use by other folks, when people can request the data we have, those data will only ever be de-identified. So we will never share that kind of identifiers.
Sure. And
I guess some identifiers, obviously, to make sure that people are real persons and all of those things to begin with. But then, other than that, the health information relevant data will be kept separate.
Well, I find it fascinating because as I was reading about your survey, and again, I'm sorry I'm keeping you longer than I said I would, but I hope you have the time. As I read through this stuff, I was saying, is there any other medical condition, pharmaceutical product that is trying to capture this? Like, does the MS Society in America have a big depository of information? Is this something new that you're doing here to grab and is it just focused on national or is it international? Like, it seems robust and new to me. I haven't seen this elsewhere.
Yeah, so currently it's focused on the US. Potentially we could expand to other places. Obviously, English-speaking countries would be relatively easy to do. No, products might be slightly different. I mean, Canada would be an obvious choice because of national legalization of recreational cannabis, pretty robust medical market, right? I think I would argue we're probably the first in the US, at least, to assess cannabis use exposure at the level of nuance that we do and at the scale, especially for medicinal cannabis. The goal is to get 10,000 patients into this thing.
But you're identifying recreational users as well, are you not? Like, if I choose to enter my name in this can I do it as a recreational user or just as a medical user?
Yeah, so, I mean, we're essentially taking people by their word that they're using cannabis to deal with a medical condition problem that they have. Now, the definition of what medical or medicinal use is not, there's no one type of way to define it, right? Mm-hmm. Back in the day, maybe you could have taken whether or not somebody is registered through a medicinal cannabis use state program. They've talked to a provider, they've gotten what might be called quote unquote a medical cannabis card. But now in a state that is recreationally legal, you can just walk into the dispensary, buy a product, use it because you have a headache or what have you. You never talk to a provider. I would argue that person is a medicinal cannabis user, but they wouldn't ever show up in a state registered list of patients, right? I mean, you could walk into a CBD shop that is outside of the state system altogether and use CBD because you think it helps you with anxiety or with sleep or what have you. So that definition has gotten very tricky, and we do see in states that go from, usually the transition of states is that cannabis is not legal at all, then they have a medical program, and then eventually they go to full recreational adult use legalization. That's kind of been the trajectory in, I'd say, most states. And once we see the transition from just a medical to a recreational use, then you see that the recreational market takes a big bite out of the medicinal market, that people just don't get a card anymore. They just go to the dispensary and get the product. Whether or not, and states are very different in how stringent they are in allowing for medicinal use, like qualification. So there's no standard across the country. And so, whether or not people just want to get cannabis and they qualify because of some kind of condition, and it's really tricky to say, right? Not everybody will meet the same criteria.
Yeah.
But what we see is that once states come online with recreational use, then medicinal use tends to go down.
One question on the data, and then I'll sum this up. The data repository, that is when you're asking people to submit their records, right? I know some states are collecting information on medical cannabis. So are you getting good response from other practitioners that are giving you their information?
Yeah, it's a big tent approach we're doing here, is to reach out to folks, and really anyone who has relevant data sets to contribute. There is a process that we have set up with our IRB here at Hopkins to govern essentially, data use agreements and transfer agreements that folks can collaborate with us and deposit their data into our repository. Because a lot of the time, if you live in the kind of soft money research world, you run a study, you collect data, you maybe get your primary paper out, and then a lot of the time you just have to move on to the next thing. And then there's still a data set that has a lot of value potentially, especially when you can potentially combine it with other data sets that then all of a sudden allows for analyses with much larger sample sizes, right? Where you might be getting to a meaningful number of folks with conditions that we wouldn't see in like a one-off survey, or, we'd only see like a handful of folks for specific conditions that are not as common as chronic pain, anxiety, PTSD, insomnia, like the big ones that you see in all of the surveys, but where cannabis maybe has potentially a lot of promise. And so by combining data sets and harmonizing in a repository like this, we could potentially make a meaningful contribution to improving the data quality and the sample size that is available to get after these questions.
Completely agree with you, sir. Completely agree with you. Are you getting a good response? Are people responding to you? Are they saying, yeah, we'll share this stuff with you? Is it happening?
Yeah.
Cool.
Yeah, for sure.
Cool.
But we always, we're always interested in more, obviously. If folks are interested, yeah.
Now, did I read someplace that you're accepting international databases for that response? So if somebody in Canada had information, you're accepting international data repository, whereas the national survey right now is strictly America. And are you, U.S., sorry, and are you also eventually going to all that's going to jive and become the library?
Right. So the library is just papers, but the repository potentially, this is kind of, we have to see a little bit as we go based on what kind of measures are collected in individual data sets. Is there potential to harmonize across data sets? By harmonize, we mean, this study collected insomnia in this way, and this study, another study, maybe in another way. Is there a potential to kind of combine these measures? For some studies, some data sets, I think that will be an option. For others, maybe not so much. It depends a little bit on what we see in the data that we actually receive. The other thing I will say is that we talked about the cannabis use questionnaire that we have on the website. We also have a suggested list of assessments for health outcomes or health aspects around cannabis use that we suggest folks use in studies on medicinal cannabis. We call that the CABC, so the Cannabis Assessment Battery. And that is also on the website for download, so people can see, core assessment battery for cannabis. That what are the measures that we recommend for the field to use. And this is also a step in that direction of might make it easier moving forward to harmonize across different studies and across different data sets. If some of those measures are used consistently across studies, right, obviously it will become much, much easier to then build larger and larger data sets to get at where the signals are on cannabis use and health.
And when do you feel it's going to be accessible? How, like, where are you and the timelines that you're going to say, hey, we've got the information, it's now accessible? And you did say it was a year-long study. So is this something that will make, I guess funding determines this, but is it going to be an ongoing thing and progress as long as funding's there?
Yeah, that's certainly our goal, is to keep this thing alive for as long as we can.
It's a huge project.
Get more data in and build something that can be really useful to folks in the space and to the field.
Well, and as we said right up front, cannabis is such a misunderstood substance. And I think from what I've heard from other things I've read, and Trevor and I will fill in the blanks of stuff, but I think it's really quite cool. Is there any question I didn't ask you? Is there any information that you would like to share that I didn't get into?
I think we've all covered it. I would just say we're a very collaborative group, and if folks have an interest in working with us, in contributing to the repository, in using the measures that we have developed, just an open invitation for folks to reach out. And maybe potentially even the platform that we've built, if someone says, like, I want to run a study on a specific patient population and could funnel them through our platform, collect the data will go into a repository anyway, right? Mm-hmm. That's always an option as well. We maybe don't all have to reinvent the wheel for new studies. If this platform meets your needs, we're also super happy in collaborating.
All right, so Kirk, I'd like to summarize stuff to see if I'm understanding what I'm listening to. So here's how I understand this sort of three-part, we'll call it database. So the first chunk is the National Cannabis Survey. So it's an actual first-hand asking people, hopefully before they've started using cannabis for their medical condition, asking them a bunch of questions, your age, sex, whatever, what kind of cannabis you're using, and then hopefully after they've used it for a while for whatever condition, did it work. So that's kind of the National Cannabis Survey. Part 2 is a database repository. So this is info, secondhand info from other studies, maybe insurance companies, maybe practitioner notes, but a bunch of data that's been de-identified, so you don't know who the patients were, and dumped into a big data pile that can be queried. And then their work on things like data collection, standardized data collection tools, and ways to integrate all these various bits of data together. And then the third thing, a research library of actually published cannabis papers. And I was just flipping through that this morning, and I think there's 100 years of podcast ideas and research just in there. It was 3,000 plus papers just in that third part. So yeah, this is big and interesting and exciting. And do you think I sort of got the summary half-assed right?
No, you nailed it. And that's what I stumbled into when he responded to my original emails. I went in and said, okay, who are you? And wow, look at what these guys are doing. The intent is to build a platform of data collection that they can basically have a repository of cannabis information. It's fascinating. And I kept trying to ask myself, and I don't think any other database like this exists, like EMRs, like electronic patient records. are just now starting to come up. I mean, I can remember in the 90s, I had a very progressive family doc, Dr. Lindsay, Peter Lindsay. He has passed since, but Dr. Peter Lindsay was a very progressive family doctor. He liked technology. The man just loved technology. And he moved from Lac-La-Biche to Grande Prairie. And I went to Grande Prairie to see if I could get some employment in Grande Prairie. And I met Peter and hadn't seen him for a while. Peter used to be my medical director when I was a paramedic professor a college professor for paramedics. Peter back in the 90s showed me his room, his computer, that was a electronic patient record, and it like revolutionary, right? That's 30 years ago. Peter was doing this. And then of course I moved to Manitoba. Manitoba's a little, yeah, I don't know. I don't want to say backwards, but slower. It doesn't catch up to Alberta in that sense.
Backwards is fine. Backwards is fine.
But EMRs to this day are still limited. I mean, not a lot of places have EMRs. I think your clinic has an EMR.
We do, and well, trying to get too far. Yes, and I've my whole career, I couldn't wait for them to have. Well, they've had electronic medical records, but of course the part that affects me the most is they have electronically generated prescriptions now, which should have been the fantastic for all pharmacists everywhere. You know, the famous, I can't read your writing, or what did they say, or which doctor signed this, should all be over now, right? Yes, but I didn't realize it introduces new problems. So the new problems being, you know, if you write it down on a piece of paper, you don't pick a completely wrong drug. You know, you might spell it wrong. I might not be able to read it, but you know, if someone has high cholesterol, you wrote down a cholesterol medication. Well, now that they're picking their drugs from a drop-down menu, you know, someone might have a cholesterol problem and they picked a birth control pill because it's so easy to pick something wrong off a drop-down menu. So that's annoyance number one. And annoyance number two is with written prescriptions, you would physically get that from your doctor and walk over to the pharmacy and hand it to me. Every so often, you know, a couple times a month, especially coming from the emergency room to us, patients would lose that piece of paper between the emergency room and here, and now it's a big struggle to figure out where the hell it was. That should all be over with electronic medical records, right? Nope. Apparently, it is phenomenally difficult to hit the print button that goes to the pharmacy. Several times an hour am I trying to call up doctor's receptionist to see where in the ether this prescription is, because the print button wasn't hit properly to go to the pharmacy. It's just lost in the ether. They can find it, but it's annoying. Patients come and assume I'm the idiot that I didn't get. The doctor said he sent it. It's not here. They didn't send it. And even worse is the hospital. The hospital has no idea how to send anything out of the hospital to somewhere else. And of course, when you call a hospital, you go through 14 different people till you get to the right person who might know where. Again, I guess the good news with electronic medical records, they'll eventually find it. But, oh my goodness, I'm not trying to be a Luddite, but things went so much better when the doctor wrote it on a piece of paper and handed it to people. I don't care that I couldn't read it, at least I got it. All right, sorry. Rant over. Electronic medical records, you were saying?
Sorry, I was just having this flashback as you're talking to me about communicating with doctors, and it's always killed me how everyone else in the system must communicate and use proper language and are evaluated by how you communicate. But a doctor can come in and write something and scribble it, and you can't read it, so you phone him at 3 a.m. saying, "What is this? What have you written?" And you get in trouble for waking him up. Anyways, that's doctors in their communication. I mean, yeah, no, electronic records, right? So I've had 30 years of understanding that they're out there, right? And when I worked up north, the federal government, I think there was 2 nursing stations that were moving into EMRs. The whole point about EMRs is that EMRs are supposed to be able to make things easier, and you would hope they talk to each other. Like one of my biggest pet peeves in the healthcare system, and this is my rant, is that we are told everyone needs a family doctor. I don't believe everyone needs a family doctor. I don't think the most important relationship is between patient and doctor. I think the most important relationship is between citizen and government. So if I go to Alberta and I get sick, I should be able to walk into any physical doctor's office, but unfortunately they're private entrepreneurs, but I should be able to walk into a healthcare clinic. They should be able to call up my EMR and say, oh, here you are, Kirk. Here's your EMR that your doctor and Dauphin wrote out. And I can see that here's your, and carry on with my care. But the problem with EMRs is that they become silos. So my doctor has a wonderful database on me, but if I want to share that when I go to BC in a couple of weeks here, and if I fall off my perch in British Columbia, they have to start from fresh and probably have stuff faxed to them. But my point being is that EMRs should be talking to each other, but they're not. But here we are. We have cannabis. We have cannabis and this national database. What other medication? What other I can't even think of a word, because is a medication condition has a national database. And I was trying to ask him if he knows of anything. Like, does the MS, is there a national bank of MS patients? Is there?
No, and this is a very cool thing. And it's not the EMR's fault. It's the fact that healthcare is provincial, not federal in Canada. But the reason I can segue into that is in Europe, because we get really cool info out of Europe, like around, about whatever, but lately it's been things like, around COVID, because like England or the UK has the national NHS, National Health Service, and they can pull out, you can go anywhere in England and get connected, and they can pull out chunks of info from the whole. Well, the US is terrified of having anything linked, not even just state to state, town to town. So they are completely against anything being nationalized information wise. And Canada's not a lot better. But back to in North America, no, big national databases on stuff almost don't exist. But I want to throw in, so one of the things with EMRs is the docs originally were supposed to all put in ICD-9s, these fancy codes to say, this person has high cholesterol and this one has diabetes. It's a code to make it easier for a computer to find it and collate and do something with it. And sometimes they did it and sometimes they didn't. And sometimes the EMR would work well and sometimes it didn't. But what until now has been very difficult is the doctor's notes or the practitioner notes, the freehand, like typed in there, because it's basically a story, right? I saw Kirk and he had a big purple toe, and then he told me about his, his mother's dementia.
You're talking about soap charting.
Exactly. And I was going to explain soap charting, but I don't do it very much. So Kirk, just quickly, what's a soap chart?
Soap charting is just that, subjective information. Why the patient came in, what is the patient's complaint, what is the patient's story. The O is objective. So what do I see as a practitioner? What is my assessment? So the person comes in with a belly pain. I do a hands-on physical assessment, and that's my O.
Right, their blood pressure, and.
Well, but my observation, my observation. A is my assessment. So my assessment is, and I've said this before, you get a differential diagnosis when you see a doctor. The doctor never tells you what you got. He tells you what you don't have, and he goes through the negatives until he gets to, then it must be this. So you provide your differential diagnosis, meaning it could be this, it could be this, it could be this, and then you go with your plan. So SOAP, SOAP, and what is my plan? I plan this. So your plan should relate to everything the patient says and your assessment. What sometimes happens that becomes very difficult, and this is where I formed a real appreciation for the family docs, is that sometimes the objective and the subjective don't match. The patient comes in with a subjective story and you do your objective assessment. You go, there's something missing here. And that's where it becomes difficult, because sometimes the patients are coming in hunting for meds, hunting for the narcotics, hunting, I've got severe pain, doc. So there are ways to elicit a pain response from a client, and you can do it, I can't never say the word surreptitiously. I can do it secretly. Yeah, as I'm assessing and touching the patient, I can throw a little to see how they respond, and sometimes you don't get the response that you want. But so a soap chart. So in the federal
But
system.
I'm going to jump in, though.
Yep.
The reason we went on this rant and how it really does go back to Dr. Thrul's project is computers had a hard time reading narrative stuff. Taking a narrative like that. But now with AI, and he mentioned that, now AI actually can look at narrative stuff like that and make sense of it. And more, you could do that with a human, going and picking out. They could. A human can do a few, maybe a human can do 100. A human can't do 1,000 or 100,000 or 1,000,000 narrative reports. AI can. So that's one of the cool things about them using AI on this is if you get a bunch of these narrative reports, it can still pull out the useful information and try and categorize it.
Yeah. No, I found this a fascinating. Project that they're working on. I could go on and on about medical records. I mean, moving from one province to another, the public health department was amazing. I got our immunization records for the family easy. And, I went from one public health office to the other. The difficulty is working between doctor clinics, but that's a different story. So looking at this National Cannabis Study, there's a large team. It's out of the Johns Hopkins University Hospital. It's a study team. What I found interesting is that they seem to be psychologists and psychiatrists opposed to like their PhDs. There's not a lot of medical doctors on this team. It seems to me, unless there are some medical doctors buried in the PhD. This is truly an academic project, which makes it unique.
Yeah, no, and I think that's probably the place to start anyway. These are the researchers, these are the guys with the training and the stats and whatnot. But I also want to throw out there, so that was the good part of AI, the AI should be able to sort of pull information out of narratives. The bad part, and he mentioned, is their survey has already been attacked by AI bots. So because you can be offered money to do some surveys, well, there's money to be made, so let's unleash a bot storm at this survey already. So they've locked that down, but like everything else, there's just every new technology, there's wonderful things it can do and terrible things, and yeah, the AI pulls out stuff from narrative, great. Attacks the whole damn survey, not so great.
Yeah, one of my mentors years and years ago always said to me, Kirk, this is great. We're problem solving. This is fantastic. You've come up with a solution, but now remember that all solutions come with their own problems. So you can come up with a wonderful idea, but you have to now critically think about what are the limitations of the solution. I don't know. When I went into this story and spent my 3 days studying it, I really can't see any disadvantage of it, except the fact, what I know about the United States is that no state likes feds. I mean, any novel I ever read, any TV show I ever watched, when there's state and federal issues, no one likes each other. So I can only imagine that there's going to be reluctance, because this looks like a national project, but it's funded out of, I think it's funded out of Colorado. I don't have that reference in front of me, but I think I heard that because I listened to a couple other podcasts that this team was on, so I could listen to their story from other podcasters' perspectives. And I believe the funding's coming from Colorado, but yet it's Johns Hopkins, and I think they're in Massachusetts, right? They're in Boston, aren't they?
On the East Coast anyway. But I think the good part, like you said, we have our provincial silos, and Ottawa better not tell me anything about how to run my healthcare in Manitoba. I think there hopefully should be less reticence, but this isn't run by the federal government. So the fact that it isn't being run by the government should hopefully make the states a little less worried about being involved.
Yeah. couple things I should, ranting about EMRs and stuff. A couple things I should pull out though that I thought was interesting that I'm going to explore further with other members of his team. We discovered that one of the members of his team is actually an alumni from the U of A, University of Alberta, and I'm going to investigate some of the stories that she did in Canada. But one of the things was the Cannabis Use Questionnaire. They have standardized a questionnaire for cannabis use, and they call it the CUQs. And what they hope to do is that if any researchers are out there that are doing cannabis-related research, they have a standard set of questions that they want to encourage you to add to your survey so that consistencies are seen. And this is what interested me when I discovered this story, was that what these guys are doing is, I think, revolutionary from a perspective of understanding how cannabis affects people in a standard wise. So it's very academic. And it's basically across the spectrum. And go to our webpage, reefermed.ca. The links will be there, and it's all participatory. You can sit here and fill out the forms if you want, and add your information to their database. So
yeah, no. Very, very cool, and sorry about the rants afterwards. But Dr. Thrul, that was great, and we wish the best to your team and this repository of information about cannabis. It's going to be fantastic. We're looking forward to looking at it afterwards and hearing some more research that come out of it. Keep us in the loop about how it goes, because I can't see anything but good things coming from this.
Yeah. We're Reefer Madness, the podcast. I'm looking for Canadian stories. As I said earlier, I have sent out many requests in the last couple of weeks I went to AI, Trevor, and I asked AI, I said, give me some Canadian research stories on cannabis. Like, what's happening with cannabis in Canada? And it didn't give me a lot. It gave me about 5 names.
Well, the good news is our listeners are smarter than AI. So listeners, if you know of some Canadian cannabis research, tell us. We would love to include them in this. Our listeners are smarter than AI. Prove me right.
Yeah. No, let's get some Canadian content in this podcast, because it's not that we're not looking for it. It's just not coming our way. This is an American-centric story, but again, the information is relevant, and I think researchers in Canada who are doing cannabis research should look at their Cannabis Use Questionnaire. So again, questions become standard. I mean, that's the thing about research, is keeping things standard so that they talk to each other, right?
Absolutely.
All right.
So, been another good one. Have a good day, everybody. We'll talk to you next time.
Cheers.
Check out the complete library of Reefer Madness episodes at reefermed.ca. And make sure to follow us on all the socials for bonus info on what Trevor and Kirk are up to.
My camera just broke, so I don't know if you've noticed, but I've been leaning here. My camera just broke off of my computer, so
I guess that's the sign that
the sign
the camera has decided this is enough.
Yeah.